Yeah, why don't you? So Mike Lopez is going to just do a quick introduction here, and I'm going to figure out how to make my slides visible. Okay, go ahead, Mike.
So good morning, everybody, and welcome to the Paramedic meeting for March. That's somewhat of a misnomer because we're really encouraging everybody in EMS to view Joel's lecture today. There's going to be some great information. I wanted to take a minute to just kind of set the table. This virus, the COVID-19 virus, is not unlike any other virus that exists in the world, with the exception of, obviously, it's highly infectious. But really, viruses have one goal in life, and that's to replicate and perpetuate the species. Nothing at all other than that. And they do that effectively by moving between hosts. When their concentration in one host gets high enough, it's time for them to move on. And typically, they will be expelled either through the GI tract or the respiratory tract. In this case, it's respiratory. So when a virus gets saturated in one host through the droplet means of either a sneeze or a cough, it moves on to the next host. If that host is a young, healthy person with an active immune system, that virus won't sustain itself, and it will move on to the next person. That's how we get the transmission. And that's why some of the things that have been enacted, such as social distancing and use of PPE, things like frequent hand washing, are all strategies that are effective in limiting the progression of this disease. Some things that I'd like to just point out real quick is that this virus is not partial to any one person or group of people, although we are seeing older people having more deleterious effects from being infected. It's not a particular gender, it's not a particular group of people, and we really need to make sure that we're compassionate in our care with individuals as we interact with people that maybe we know are testing positive for COVID-19. We really need to avoid stigmatizing people. This is not a disease associated with any group of people or person, so please keep that in mind. And finally, I just want to reinforce the fact that your safety, the safety and health of your families, and the safety of all of your coworkers is extremely important. Be diligent. Use your PPE in accordance with the protocols. Make sure that you're practicing that social distancing. Make sure that you're doing frequent hand washing, and take care of yourself. Look out for one another. And finally, just take care of yourself. Take time away from work to get out. You can still take a hike. You can still go play golf if you play golf. Get out and do things for your own mental health. And with that, I'm going to turn it over to Joel and learn lots.
Thanks. Without further ado, let's move into this. So first, I think we need to reiterate at the opening of this discussion, and that needs to be on the forefront of everybody's mind, is the fact that as healthcare professionals, we're going to be looked upon as leaders in the field and leaders in a crisis. So I would hope, and really I would expect, that all of you as EMS providers and community leaders in a disaster like this would act in a way that's professional and be a voice of reason in what otherwise is kind of cacophony of sound surrounding this topic. So I know there's people that believe that a lot of this is hyped up hysteria. I'm sure there's a number of people that believe that this is a conspiracy theorists, I'm sure we'll have a heyday with this. But right now we need to have a unified message. And as a healthcare professional and someone who is committed to public safety, we need a common message about the seriousness of this with a calm voice of reason. So don't contribute to the hysteria. Don't make unsubstantiated statements about the disease in our community. This is probably going to turn into something. Don't make it, don't wish it any worse than it already is. And then I think also we're all going to have to be very adaptable. And anytime we have a disease, we need to acknowledge the fact that disease is a dynamic process. And it's going to change. Our supply chain is obviously stressed, and we're going to need to adapt as our supply chain on PPE is compromised, and sometimes will be restored and compromised again in what our workforce will look like. And we may be asking people to work in an extreme circumstance that otherwise would have warranted time off in quarantine. And we'll talk a little bit about this later, but the truth of the matter is that we're in a emergency declaration which was made by the state and has been done so by neighboring states, and that requires that certain things are going to take place that are not the norm. And so we're going to ask that everybody understand this and work together as a unified voice to make sure that we're managing this disease in the most responsible way possible in our community. So let cooler heads prevail, I think, as we start to head into what could be a very difficult and trying several weeks and months ahead. So I'm just going to start out with a little bit of biology, right? Because I like biology, okay? Particularly, we're going to talk a little bit about virology. So what's a coronavirus? So coronavirus is an enveloped single-strand RNA virus. It's been around for a long time, but was first described in the 1960s, and it's called a crowned virus, is what corona stands for. And if you look at it under a microscope, you'll see on that top right-hand photo or image that it has a nice crown-like appearance. So that's where it gets its name. It causes a respiratory syndrome in humans and was initially described in the 1960s. There's variable severity. Most of this is very mild. It makes up about 25% of common colds, well, 13 to 25% of common colds in the community. There's a lot of different strains of the coronavirus. And most of them are untested for and presumed to be the usual sniffles, cough, and cold that run through the community at any given time during the winter. On rare occasion, we get a rather virulent strain that runs through the community, and that's what we're seeing right now. And we'll talk about why that and those incidences have occurred historically and why we're in the midst of one today. So the SARS virus of 2003, which is a severe acute respiratory syndrome is what that stands for. The Middle Eastern Respiratory Syndrome, which was in the, I believe, 2013, I believe is when that first presented itself. And then presently COVID-19, and that 3% mortality on COVID-19 is just an estimate right now, but you can see that that's less than what we've had with other virulent strains that have jumped species in the past. SARS 2003 had a 10% mortality rate. MERS had a 30% mortality rate. Part of the dilemma that you know and you've heard about is that since we've discovered and described the coronaviruses, we have not come up with a successful vaccination program for it. So we don't have those in place. Most of the time it's because it's not a terribly virulent disease, and so really the demand has not been there. And treatment up to this point has just been supportive care, and most people manage that quite well at home with good hand hygiene, a little bit of chicken soup, and good rest. So That's our history of coronavirus over the past, what is that now, 60 years. That's been our familiarity with the disease. So how do we get these bad strains? And the term is called species jump, and it involves an interspecies host transmission of a pathogen from one species to another. So I take a disease that's common or prevalent in one species, and it jumps to another species and becomes subsequent species becomes a host. So this is typically a result of random mutation. The rate of random mutation in pathogens like bacteria and viruses is relatively rapid because their reproductive rate or replication rate is quite fast. And so the opportunity for error when transmitting a genetic code from a parent to child, for lack of a better term, is increased. So when I have lots of replication or duplication of a genetic strand, I increase the rate of or the frequency of mutation, and just by random mutation, I get traits that make it transmissible from one species to another, where previously that trait was not present in the genome. It usually requires some sort of contact between the species so that they could take advantage of that genetic mutation. Some of these transfers involve pathogens that develop variations that make them more virulent, and that's generally because they have an opportunity to overcome the typical barriers that a new host will have when introduced to that disease process. So you kind of have to have, it's a bit of a Goldilocks phenomenon where if I have a species jump of a pathogen to a new host and it becomes extremely virulent, then I kill that host before I get an opportunity for significant viral replication, and that dies out, right? So I don't really create, I kind of burn up all my fuel in one flash, and I'm not a very good pathogen at that point because I kill everybody that I touch immediately, right? Or in a very short order. So then those tend to peter out very quickly because there's a lower transmission rate because all my hosts die too quickly. The other, which is kind of this porridge is too cold scenario, is that the virulence is so mild that it goes undetected in the community, or is just presumed to be a standard run-of-the-mill flu-like illness in the wintertime that doesn't gather or garnish the attention that some of these other strains have. Mike Lopez got a question.
So, in relation to that, it's not to the virus's advantage to kill people. Is that a fair
Right,
assumption?
so from a virulent standpoint, if you could reason with the virus, you would say, listen, buddy, if you really want to be effective in your job, which is to make people sick and replicate and infect as many hosts as possible, you got to stop killing people so fast, right? But since it doesn't do this voluntarily, it's just purely random, and the selective pressures will really create an opportunity for, or I shouldn't say the selective pressure, but the environment that this strain finds itself in will determine how much of an impact it makes on its host. So yes, if I kill my host too quickly, that is not advantageous to my strain. If I don't do any harm and I'm rarely recognized, then sure, I can probably do just fine in the community, but I'll go undetected, and I'm just going to look like every other coronavirus that's really not that bad, right? But when you get the porridge is just right scenario for our Goldilocks analogy, then now I have an opportunity where I can thrive in a new host, because that new host does not have the the recognition or the ability to overcome this new virulent component that has made this virus so dangerous to a community. Does that make sense, I hope?
Yep.
And if you're gathering any questions on this stream, just let me know, okay? So this is not new to COVID-19 and SARS coronavirus 2, right? We've seen this lots of times in history. HIV, 1930s, that's a species jump from primates to humans. Ebola, 1970s, believed to initially be in a host population of bats with an intermediate host of primates, and then from primates on to humans. The SARS coronavirus in 2003 was a bat original host with a species jump into humans. H1N1, swine flu. Obviously, the origins of the H1N1 influenza strain with swine flu was pigs. MERS, or the Middle Eastern Respiratory Syndrome of 2012 and 13. The host is in bats, but the intermediate host of camels. And so camels became an important host or intermediate host for this disease. Now, what about COVID-19, which we're currently in the midst of? The best evidence suggests that this comes from bats originally with an intermediate host, and we'll get into that and why we think this took place. But put that on hold for just a moment. So typical coronavirus generally is a wintertime illness. It very closely replicates the prevalence of influenza in our community. You can see there is seasonal variability to a lot of viruses. One of the things that people are saying and circulating is that this is going to peter itself out at the end of April because that's what coronaviruses do. I think that I would love for that to be the case, but I don't think that we can definitively say that, partially because, one, we don't quite understand the unique nature of this disease. Two, it seems to be surging at a time that it's unlikely to peter out at the end of April. And if we look back at other SARS-like events, you'll see that these diseases, while they peaked in and around this time, lasted well into the early months of the summer. So here's worldwide SARS of 2003, where we had a peaking in March extending into April, but the disease process carries out well into June and sometimes July. Now, worldwide cases, keep this in mind, this is an N of 7,500. We'll talk about where this is relevant in the future here, okay? This graph includes all of the cases that were reported to the World Health Organization, as you can note in the subtitles there in the bottom. What about the MERS? So MERS, which was in the 2000, this is confirmed cases and deaths of the Middle Eastern Respiratory Syndrome that evolved in Korea and China in 2015. And you'll see that this started in May, in fact, right around the time that it's supposed to peter out according to our coronavirus calendar, or our typical virus pattern calendar that we previously looked at, and lasted well into June and July. So I don't think that we can just say that this is going to peter out and go away like all coronaviruses do. I think that would be underestimating the nature of these species jumps, events, and the pandemics in general. So specific to the SARS coronavirus 2, which is the name of this virus, SARS coronavirus 2, which stands for Severe Acute Respiratory Syndrome Coronavirus 2. That is the name of the virus. The syndrome, the clinical syndrome where people experience symptoms, the clinical disease, is called COVID-19, or the coronavirus disease 2019. So when we believe that we have had an exposure, or what we're calling COVID-19, it's exposure actually to the SARS coronavirus 2. The clinical manifestation of that is the COVID-19. It originated in Wuhan, China, believed to come from what are called wet markets, where there is a large population of animals and people gathering in a common location. The natural reservoir is believed to be bats with an unconfirmed intermediate host. Most of the genetic makeup of the SARS coronavirus 2 resembles coronavirus that is identified in this subspecies of bats called a horseshoe bat. It's believed that the horseshoe bat then had an intermediate host to a pangolin. None of this is absolutely 100% confirmed, but based on genetic analysis and RNA analysis of what we know in this syndrome and this present pandemic, most of it aligns with what we see in these two species. The pangolin is one of the most highly illegally traded wild animals in the world. It has medicinal health properties in traditional medicines of the East, and frequently is seen in these wet markets. It's kind of a hotbed for these species jump events, and you'll see that SARS, swine flu, a lot of these events were believed to come from these types of environments where you have an incredible amount of people and an incredible amount of animals gathered together in a common place, overcrowding and suboptimal sanitization in those locations. So started out as a Wuhan virus. The problem with naming things after a location is when they are particularly virulent, like we're seeing now, it no longer is relevant to call this a Wuhan virus. This is a world virus. If we're going to name it after what it is at this point, it becomes a world virus, right? It's everywhere. So we really like to stay away from localizing this to a single location. So anytime I get something where I have potential for serious illness, right? I have a setup for a serious illness, plus I have sustained transmission between hosts. So this is a serious potential for serious illness. I didn't wipe out all my hosts in the first week because I killed them all, right? I'm not that bad. And I'm not so bad that I'm minimal threat, so I don't pose any serious illness to anybody, but when the porridge is just right, again, back to our Goldilocks analogy, I have serious potential for illness. I have a setup for sustained transmission between hosts. And in this day and age, worldwide spread is very easy. All I got to do is jump on a plane. I got to fly for a couple hours. I'm in a new city. I get off in a crowded location. I take mass transit to my hotel. I go to the mall. The opportunity for worldwide spread is a common part of our day-to-day living and in this kind of global world and environment that we live in. And that sets up to a pandemic. And this is now officially considered to be a pandemic. So it is likely that this virus is going to continue to spread throughout the United States. We know that we are going to be in close contacts with patients with the COVID-19 syndrome, and we're going to be at increased risk of exposure. Initially, efforts were at containment of the disease and avoiding travel to and from and isolating people who had been in regions of high disease prevalence. And initially that was China, South Korea, Iran, Italy, and Japan. So our initial screening heavily relied upon evaluating people with flu-like symptoms who had recently been to these countries or in contact with somebody who was sick and traveled to these countries. But this has spread beyond that, and we're rapidly seeing these criteria as an identifier of risk to fall away. And we are out of what is to be considered a containment strategy for this disease. So this is as of 8:13 this morning. So I'm behind by a little bit, but this is the latest update for the coronavirus status. This is an interactive map through the Johns Hopkins University, which is pretty damn good. Total confirmed numbers, 187,000 Remember when we had looked at the numbers surrounding SARS in 2013, that number was not near this level. So this is far more widespread and global in comparison to the previous SARS events or the Middle Eastern Respiratory Syndrome. So we're looking at numbers that far exceed what we've seen in the past. That's part of the alarm. Total deaths, just about 7,500 worldwide. Most of those obviously have happened in China with 3,000, a little over 2,000 in Italy, close to 1,000 in Iran. Spain is creeping in there. France is creeping in there. What I'd like, 55 deaths in the United Kingdom. But right under the 55 deaths, 48 deaths, what you can't see here, this is Washington State. Okay, so we made the top, 1, 2, 3, 4, 5, 6, 7, 8. We made the top 10. Washington State hanging in there with the big time, big league, big countries, right? So we are in a situation that demands a serious and organized response from our community. Hence the structures and command systems in place to help address this in the most appropriate, efficient, and responsible way. Okay. What do we know about COVID-19? Severity ranges from asymptomatic infection to severe and potentially fatal illness. Most severe respiratory symptoms appear to peak after 1 week of infection or 1 week from the onset of disease. We see acute respiratory distress syndrome anywhere from the teens to the mid-teens to 30% of hospitalized patients. Treatment is supportive care. Again, we don't have any large-scale vaccine currently approved or available for use, although you're seeing accelerated testing and research into these areas, which is all over the news. Our initial strategies, as I mentioned, were aimed at containment, but now that's going to be at managing transmission of the disease. As containment, this disease is not contained anymore, right? And so slowing transmission is going to be our strategy. So community mitigation efforts and infection control at this point are going to be our best strategy for reducing transmission. Who's at risk? The high-risk populations for serious illness are going to be our elderly folks and people with multiple comorbid conditions. So people with chronic renal insufficiency, people with diabetes, people with COPD, people with heart failure. That's going to be our high-risk population, folks that we need to be particularly careful with and vigilant for the disease and the potential for severity in them. The lower risk for serious illness is healthy adults, pregnant women. Although pregnant women are considered to be immunocompromised to a degree because they have a parasite growing in them, we haven't seen that they've been markedly selected for by this virus in terms of poor outcomes. And then, as we've all heard, children seem to be relatively resilient to this disease. What I would caution everybody is that because we see serious illness in people with multiple comorbid conditions and in the elderly, it doesn't mean that the disease is in that population. The disease is in all populations. Some people tolerate it better than others. So when we say we want social isolation and kids are out of school, it doesn't mean we get together and we have play dates because kids don't get it. And that's one of the rumors that circulates, is that healthy people don't get it, right? Healthy people do get it. You don't feel that sick 80% of the time, according to our statistics, and you manage everything at home, but you still spread the disease. So if I feel great because I'm a 24-year-old stud, unaffected by this disease process, and I got energy and I got lots of time now because work is shut down, the jobs are slow, I'm going to go hang out with my buddies, right? We're going to go to the bar, we're going to have a couple of beers, and that's how this disease is going to spread. It's going to spread via transmission through folks that are low risk for serious illness, who feel like they don't need to abide by the rules of social isolation, and social restriction. So this needs to be a community-wide effort and acknowledgement that everybody can carry this. Not everybody will die from it, but your irresponsibility in your management of this and concern regarding potential for transmission will definitely contribute to the severity of it in our community. Okay, I want to make that very, very clear. There are some unique characteristics that may contribute to the transmission and why what I just mentioned is the case. It appears that the SARS-CoV-2 has high viral loads that are detected early in the course of the disease. So people that are mildly symptomatic can have viral loads that are equivalent to people who are in an ICU. And that can be spread by folks who are minimally symptomatic from one person to the next. Again, children appear to be less symptomatic and may play an important role in disease transmission. About a week and a half ago, I was talking to somebody about when we start to see this pop up in teachers, we know that there's a higher prevalence than what we expected in our community, right? Because these kids are going to be important vectors. I believe, this is my theory, I can't prove this, and I should be careful about what I'm stating as an expert here, but I believe that these lower severity cohorts in the population are going to be a very important player in disease transmission. So we got to look at who are the lighthouses for the community, and I think it's going to be teachers and people who are around kids. And if kids don't get it, it's going to be the teachers because they fall out of that resilient group, so to speak. And this probably explains why this pandemic is becoming more of a global event than prior SARS events. Again, a lot of this is theoretical, but this tends to be the consensus of most experts at this time. Any questions up to this point before we get into community mitigation efforts? Any questions at this point where I could stop and promote a little bit of discussion here in regard to the virus, characteristics of the virus, characteristics of disease transmission. We'll get into strategies and protocols for folks that encounter symptomatic individuals later on. So let's not get into that just yet, but just general questions about the SARS-CoV virus 2 itself or the COVID-19 syndrome. There's a bit of a delay, so I'm just going to drink my coffee here a little bit. I'm going to wait and see if anything comes off because there's a little bit of delay in the Nothing? Okay, good. Let's move on. So, community mitigation efforts. You've heard this term of flattening the curve, and this is a diagram that I think a lot of people have seen. I just want to take a moment to try and explain what that is and the importance of it. So you can see that in a highly transmissible disease, the rate of prevalence, which is the amount of disease in a community, total amount of disease in a community, is exponential in terms of growth, where we see without protective measures, it quickly has the ability to rapidly accelerate and peak with a narrow width of that curve, with a lot of people affected at the same time, right? This is part of the dilemma with highly communicable diseases or highly transmissible diseases. And you can see that we have a healthcare system capacity when we operate status quo and we get hit by something like this. We have very little time to evolve in how we manage a response to a process like this. So there's two things that are very important in this diagram. One is you see a healthcare system capacity, and if I look at with protective or without protective measures, days since the first case, I have a significant amount of time from the days since the first case to where I approach that healthcare system capacity. So by employing protective measures, it gives me an opportunity of time and rallying the troops in our efforts, so to speak, to improve our healthcare system capacity. So I actually have the opportunity, as I evolve with a disease or as a system evolves with a disease process or a threat, the potential threat, I can raise that healthcare system capacity. So I can take that dotted line that indicates our capacity, and I can elevate that line with time. So I can actually increase from the time that this disease hits us, I can actually bring this line up and provide myself with more room to manage this disease process. So that's the first thing. Protective measures buys me time to respond. Otherwise, I get hit hard, I get hit fast, and I have very little time to respond. Everything I do becomes a defensive measure, okay? The second thing you'll see is that I can take this peak and I can drop the... I can't see your pointer. Oh, you can't see the pointer? So I can take the peak of without protective measures and I can reduce that peak, drag out that curve, and potentially keep myself under that healthcare system capacity where the quality of care delivered is good, right? So the goal here is to provide everybody with high quality care or the best quality care available. If I reduce that peak, then I'm going to have an opportunity to manage my population as a whole better than if I get them bolus to me all at one time. Question? Oh, I can use the mouse? Okay. So everything above my healthcare system capacity line is going to be operating with suboptimal patient care. So quality above this line is compromised. Quality below this line is maintained. So I can get everybody all at once, and I can treat everybody all at once, but the people that fall above this line are going to have an impaired or compromised quality of care. People below this line will still receive quality care from our healthcare system. If I can drag out this curve, if I can improve my healthcare system capacity, I'll still have a high number of people affected, but I can ensure that those that are infected are all going to receive quality care. This is with protective measures in place, okay? So what are our community mitigation efforts or our protective measures? And that's what we can do. So our goal, with what we talk about next, is to take ourselves out of this peak and move ourselves into this protective measures peak. And communities that have done this well significantly reduce their mortality rates. And if you look at what's happened so far with SARS-CoV-2 or SARS coronavirus 2 or the COVID-19 in Asia, people that have experienced the SARS-1 outbreak in 2003 employed protective measures early and saw that their healthcare system capacity did better. And were able to reduce their mortality rates and significantly slow the incidence, which is the new cases of the disease, on a day-to-day basis. Okay, so they kind of flattened out and slowed and responded well. People that did not, because they have not had exposure to this in the past, did not know that you need to immediately employ protective measures, have had worse outcomes. Places like Italy, places like Iran. Right? So we need to learn from our counterparts in Asia who have had experience with SARS-like illnesses in the past, who quickly employ measures of social isolation, social quarantine, social distancing, protective measures, PPE, all of those things aggressively and early are going to make an impact and a positive difference. And you can see the difference when you look at the incidence and the growth of these diseases in those communities that have, and those diseases that, and those communities that have not employed these measures. Okay, Mike Lopez had a question.
So really, it's probably more of a statement, but I think it's safe to say that the Puget Sound area is in that high peaked.
Yeah.
And for whatever reason, it doesn't matter. And I think that the Spokane area, Eastern Washington, has an opportunity still, because of time, to keep that mound going as opposed to the peak. It's my understanding that South Korea is a model for managing this specific disease because of the perceived draconian, if you will, strategies that they employed to force people to stay in their homes. But they immediately saw that mortality rate and the morbidity rate flatten out.
So there's some, and I think one thing that we have to make very clear is that South Korea's mortality rate probably is also influenced by the fact that they tested a large amount of people, because they had lots of tests available to them for some reason or another. I don't know the politics or policy behind that. But they tested a lot of people early on. So they captured a lot of probably this 80% of people who recover well in their home that we are not testing, and most communities have not tested because of limited test availability, So when I include this very healthy cohort of people, then I can see that I can reduce the number of high mortality cases, just proportionally. But when you correct for that, and there are some statisticians who have done this quite well, you can see that even as I take resolved cases and true deaths, or resolved cases, deaths, and cases that are still in play, you can bring these lines together, and you can say that yes, in fact, South Korea does have a true reduction in mortality believed to be related to efforts that were employed early and what you referred to as perceived draconian, but very aggressive protective measures employed early and aggressively. And so despite the argument, well, they just have a lower test rate because they test fewer people, if you correct for that, they in fact have a true lower mortality rate than people who did not employ these efforts. So I think that's exactly what you said. That's a correct statement. And I think, if we were going to take this, bring this closer to home, then we're going to look at Western Washington, and we're going to say they are in a crisis standard of care model right now, They are operating at or above healthcare system capacity. And I think a lot of people would argue that they're operating above healthcare system capacity right now. We don't want to get there. So let's not be cavalier in how we approach things. Let's employ protective measures aggressively, and let's see if we can mitigate the rate that this disease evolves in our community so that we can continue to provide quality care to the people who live here. Okay? Question.
Kate Hall asked, said, I know that older populations with comorbid factors are more likely to be more negatively affected, but on occasions we hear of a seemingly healthy person have a serious reaction. Any guesses why?
No, I don't. So the question is, we see, we know that the older folks with comorbid conditions tend to do worse, but we also hear stories about otherwise healthy people who have also done poorly. Remember that all of this is a bell-shaped curve, and everybody in every age group can have a bad outcome. My understanding is that there's 40-year-olds on ventilators who are otherwise healthy in Seattle with this disease. And that's not great news for most of us who fall in that category and are going to be exposed to this. So I think Kate's point is great in the fact that, yes, we know who's going to be maximally affected by this, but there are examples of people who should not be having severe outcomes that are, and it reiterates the importance of taking care of yourself and taking care of the people that you work with every time you show up to work, and the decisions that you make when you're off work about what you're going to do in regard to community mitigation efforts, okay? There's a responsibility on all of us to do best practice at work and best practice at home. So don't go places, don't go to gatherings that have been cautioned against. Don't be cavalier in your behavior, because if it doesn't cost you, it might cost somebody that you work with closely or someone in their family. And we all need to be responsible and take care of ourselves and each other, okay? But good question, Kate. No, I don't know why the otherwise healthy guy gets it and gets vented. I don't have a good answer for that. I wish I did, because I would not do what they did, right? But what do you do? So community mitigation efforts, right? March Madness is canceled. Disneyland closed. Spring break is off. No more NBA. I had tickets to take my son and go with my best friend and their kids to the NCAA wrestling finals in Minneapolis, Minnesota for the championships, and it got canceled. And I'm pissed, but I'm understanding that these things have to happen, that we need to minimize large-scale gatherings. The stock market is going to take a hit. This is an economical catastrophe, right, which we will recover from, just like we will recover from not getting March Madness, and we will recover from everything else. It's going to be a difficult recovery, but yeah, it is a real drag, and there's a lot of disappointment universally felt everywhere, right? But there's also a population of people that are going to do quite well because of this. And we need to keep these people in mind. So how are we going to minimize transmission during our EMS encounters? And I'll talk about each one of these things individually. First one is appropriate screening. Number 2 is personal protective equipment. Number 3, minimize contact. Number 4, minimize high-risk interventions. And finally, appropriate doffing. We know that most of transmission of somebody who's in PPE is going to occur during the doffing phase, and so I want to just kind of pay special attention to that process. Appropriate screening. So right now, priority dispatch, the way this works is priority dispatch has an emerging infectious disease surveillance tool. What this does is it jumps what is in the priority dispatch system, bumps a call from a general sick 26 card to a 36 pandemic card. That's how this process works from a dispatch standpoint, okay? A lot of that depends on, and particularly early on in the emergence of an infectious disease process, has a lot to do with travel screening. So some of the big questions were around, have you been in Italy, Japan, South Korea, Iran, or mainland China, right? And if so, do you have symptoms? Then you become positive in this emerging infectious disease surveillance tool, and you bump from a 26 card to a 36 pandemic response, right? The other question was, have you been in contact with somebody who is confirmed to be COVID-19? Well, in Spokane County last week, that number was 0 if you stayed in Spokane County, right? I don't have anybody that I've been in contact with confirmed COVID-19, and I have not traveled anywhere outside of the country. So I'm going to screen negative, right? So then I stay in the general sick, generalized illness 26 category, and I don't garner a response, a 36 pandemic triage response, okay? That is how the triage tool works from a dispatch standpoint. Then that information, if I become a 36 pandemic, there's infection prevention instructions given to the family or the caller, the patient, to isolate themselves, and then the crew should be notified of that response. Okay? So that when I walk into that situation, I know that I'm dealing with a potential COVID positive patient, right? So in an emerging infectious diseases surveillance tool, it relies heavily on travel screening and contact screening to trigger that event, right? When your disease prevalence in a community is low, this is the best strategy, right? As your disease prevalence increases, obviously this does not capture community spread. That's where we're at now, is that we're beyond the emergence, the early emerging process of this surveillance tool, and the travel screening has subsequently been eliminated. The exposure to somebody with COVID or a, quote, person under investigation is still very relevant and still part of that screening tool. It doesn't mean that we are only using PPE on this population, but we are recognizing that the 36 pandemic triage will be triggered when we have these triggers or positives on the dispatch interaction. Okay, so there's a question about this. I knew there would be.
Max wants to know, can you hear me on this?
Yeah.
Can we expect this to continue to mutate like a normal flu virus would from year to year?
So I don't know what level of mutation we'll see. I don't suspect that we're going to see it mutate into something that is worse than it is. I'm sure there will be some mutation with the rate of transmission and with the rate of with the rate of transmission. I mean, that's an incredible amount of viral replication, and every time I have viral replication, I have opportunity for genetic mutation. So with the rate that this virus is traveling through the community, yes, I'm sure it will mutate. Whether or not it mutates into something better or worse, I can't say, but I would not expect it to grow arms and legs and fangs and be markedly uglier than it already is. So I think we could probably expect that it's going to present itself like it will. It's probably going to last for a long time worldwide. We've seen outbreaks from other SARS-like syndromes pop up in communities periodically. But once enough people are exposed to this, it's kind of like for the fire crews that are out there, once enough people have seen this and developed a response to it, and their immune systems have identified it and are familiar with it, then they'll be able to attack it or generate a response. So in a lot of ways, it's like a big fire that burns itself out, right? If I consume all the fuel, which are people who have never seen me before, and in terms of the pathogen, if I burn through and infect all my fuel, well, then there's nothing to infect anymore. There's no fuel to consume. So that's generally how these things burn out, is that enough people have seen that, or enough worldwide population has been exposed to it, that it no longer has the fuel to keep it raging as it is right now. Okay, so I hope that answers that question, Max. Is there another question there? Yeah.
Jocelyn asked, if a person has been sick, either positive for COVID-19 or untested, but did have suspicious symptoms for it, at what point are they no longer contagious, after all symptoms are gone or post-fever?
Okay, so we don't know, unfortunately, because we don't know a lot about this disease, right? But generally, the recommendations, and we'll get into this a little bit later, the recommendations for people who are COVID positive are that they had either 7 days since their last symptom, meaning cough, congestion, etc., or 3 days or 72 hours after fever without antipyretics, whichever is longer. Okay? Now, there's a 14-day or 2-week number that keeps popping up, and we'll get into this a little bit later, so I don't want to get in the weeds now. But 14 days is generally the number for an asymptomatic person who has been exposed. 14 days from exposure that an asymptomatic person needs to be vigilant for the onset of symptoms. Okay? And we'll get into that a little bit later. Okay? Any other questions on there? Okay. Okay. So one thing that we need to be very aware of, remember that I said that we all need to be adaptable in the first slide that we talked about. We need people to be adaptable. We need people to be reasonable, right? So a emerging infectious diseases surveillance tool early in a disease process is our best strategy, right? As this disease has evolved in our community and the prevalence increases, this is going to change. Our response to alerting what is potentially a COVID case will change. And what you can expect, and we'll get into this a little bit more later, is that our criteria for who to be suspicious for is going to broaden dramatically, right? Already in places where you see high community prevalence, anybody with a fever and upper respiratory symptoms is considered a possible COVID positive case, right? The dilemma that we get into is if we have a low community prevalence, right, and I treat everybody who's got a fever and a cough, or everybody that has a runny nose, or everybody that has respiratory symptoms as COVID, and we have a supply chain that is stressed, and I burn through 10 N95 masks in one shift, in 3 and 4 weeks from now, when my population has a high prevalence of disease, and I really do need to be using N95s on every patient, as opposed to 4 weeks prior when I didn't, I no longer have the appropriate PPE to protect myself. So our trigger point has to somewhat be coordinated with our supply chain and our PPE. We need judicious use of what we have so that when we need it, we don't burn it all up, right? It's like people who get their paycheck and go spend all their money at the bar because I just got a shitload of money. Sorry for the little kid in the room. I just got a bunch of money. I'm going to go spend it all right now. But 2 weeks down the road, I got no money left. And I still have demands, and I still have bills, and I still have food I got to put in the refrigerator. It's a bad strategy, okay? So we need to be judicious with what we have, understand what the prevalence of the disease is in our community, understanding what we know now about the disease and taking ownership of the stocks that we have and being strategic. We're slowly going to exchange these to lower screening threshold, higher use of PPE. But I don't want to burn it on everybody right now so that when I need it in 3 weeks, it's all gone. Okay? So that's the rationale behind employing some of these strategies to be responsible in how we approach the community. Okay? I'm sure that's garnished questions.
Brett is asking, what is the trigger to change dispatch codes to more generalized symptoms such as a cough or fever?
The trigger is a lot going to be on community prevalence, right? So what's the prevalence of the disease in our community? And we'll get into that a little bit later. We'll hit on all of this. But it won't be, what'll happen is, what we'll do is we'll just abandon the 36 card altogether, right? So it won't be that I have a trigger to use it. It's that we're not going to use it because it is not an emerging infectious disease anymore. It is a infectious disease that's in the community. And so what will happen is we will lower our threshold for PPE use to anybody with a fever and respiratory symptoms, right? So as we evolve, remember, this is a dynamic process. It's not going to be that I employ the pandemic 36 card in dispatch. It's going to be that we treat everybody as a sick potential patient, okay? Another question?
Asked, is there any data to support early aggressive intervention such as early advanced airway intervention?
We're going to get into that.
Okay.
I'm not going to answer that yet because we're going to get into that, okay? Yeah?
I have one question. I apologize if you already answered it. Is there a certain progress of this, as you're going to first have a fever first or a cough first or respiratory symptoms first? Is there one that?
No. So the question is there a characteristic manifestation of symptoms? So cough first, then runny nose, scratchy throat, then a fever. And to my knowledge, there is not. And some people remain very asymptomatic. Some people just have a little scratchy throat and runny nose. Some people remain asymptomatic. And some people are full-blown fever, rigors, chills, flu-like symptoms, onset, hits them like a freight train. So to my knowledge, there is no characteristic pattern of symptoms when people manifest the disease. So also, I want to say here, this is a real opportunity for us to fail in terms of how we manage this disease in the community. We need to be a united front, understanding that everybody is working together. The non-use of a 36 pandemic card is not something that we need to start pointing fingers at our communication specialists and saying, you dropped the ball. You need to understand the tool as it's being used, the strategy why it's being used, and you need to also employ our own screening when you meet a patient to ensure that all the questions have been answered appropriately, and so a kind of a secondary backup. But this is what I don't want, is to get a bunch of people telling me that the communication specialist totally botched this dispatch because they didn't tell us it was a pandemic, right? That is not how we're going to get through this as a unified force and an efficient team that attacks this and moves ahead in a coordinated effort, okay? They are doing what they have been instructed to do, and they're doing a damn good job with a lot of these questions. So I want criticisms to stay in the appropriate chain of command. If you have concerns, they go to the appropriate place. I don't want a bunch of bad-mouthing of our communication specialists because you felt you weren't notified early or fast enough. They're working off a very strict platform that has been put in place with our direction based on the prevalence of the disease in this community. That will evolve. Ultimately, your PPE choice and protection is going to be up to your initial historical interview, and we'll get into how that takes place here shortly.
Next question is there any evidence of COVID-19 transmission from infected people to animals and then back to people?
Not that I'm aware of. So your dog is probably fine. Okay, so minimizing transmission, personal protective equipment. And this is where we're going to see things evolve. So what I say today might change tomorrow, might change Friday, might change next week. But right now, this is what we have essentially agreed upon for where we are at in this disease, okay? Now, these are all minimums of what we require for PPE, okay? If you feel like you have a high suspicion of somebody, but they don't hit any of the screens, like I know somebody who was infected with COVID or under investigation, but you feel compelled to enhance your PPE, then you are not limited to enhancing your PPE. But there needs to be judicious use, right? So this is a minimum. PPE needs to be initiated before entering the scene. Low suspicion COVID-19 patients with flu-like symptoms, so a negative screen, meaning at this point I haven't traveled to an endemic area, which you'll see is quickly being abandoned, if not abandoned altogether. The question of have you been exposed to or do you know somebody who's being tested? Well, not do you know, but have you been exposed to or in close contact with somebody who's being tested for COVID-19 or has had a positive COVID-19 test? So if they say no to that, your minimum PPE is a surgical face mask, gloves, right, disposable one-time use gloves, and protective eyewear that covers the sides, wraps around and covers the sides and the mucous membranes of your eyes. Essentially, you want to protect your mucous membranes, right? I'm going to protect my mouth and I'm going to protect my eyes, okay? That is a minimum. Now, if I have known or suspected COVID-19, so this is somebody who I am suspicious that they have the disease, then it is an N95 or higher level respirator, or you can continue to use a face mask, right? But they also have to have a full face shield or protective goggles, and the goggles have to fully enclose the front and the sides of the face, okay? So protective eyewear or fully covering goggles, plus a surgical mask or an N95 respirator or higher, an isolation gown or gloves. A lot of this is going to depend on supply chain and available PPE. And it is a national crisis for everybody who has a high prevalence in their community that they're exhausting supply chain and PPE. And so things like gowns may not be entirely available to folks. And that is a reality of what may develop. We're doing our best. Every agency is. Every city is. Everybody who's been impacted by this is to enhance our stocks of PPE. That is why judicious use is very important, because when you need it, you don't want to have burned it on your people that are less likely to have it early in the course of community prevalence. Okay? Mike?
So can you address the whole concept of that transition from when this disease first surfaced here in the United States, it was always an N95 or higher.
Right.
It's transitioned based on CDC and WHO recommendations.
Right.
And does that have to do with the realization that this is more droplet conveyed
Right.
versus aerosolized?
Right, so the PPE has ratcheted down from its original recommendation due to the nature of this disease and what we believe is transmission. So it is a droplet precaution. You want to protect mucous membranes from respiratory droplets. It's much like the flu. Mucous membranes are the critical points of entry, so eyes, mouth, nose, okay? Those are the areas that need to be protected. You can achieve adequate protection with a surgical face mask and a face shield. Gloves and a gown are actually enhanced of what's absolutely required, to be honest with you, but I still want everybody wearing gloves. I think it's ridiculous not to recommend that. It's a baseline PPE precaution, right? So it's really the protection of the mucous membranes. And that is based on what we know about disease transmission.
So the essence of my question is, yesterday I had a call from a crew on scene who had assigned a single EMS provider to make contact with the patient. The rest of them were standing in the living room where the patient was in their bedroom, and they were concerned that they had been exposed because they were standing in the same.
No, close contact is defined as within 6 feet. okay? And we'll talk about the approach and how we need to have a unified and organized response to these patients. And part of that strategy is minimizing risk to a team, right? So within 6 feet is considered close. If I am out of 6 feet just because I am in a room with somebody or in somebody's house or I respond to a nursing home, doesn't mean that I am automatically at risk and have to have full PPE. It's 6 feet is considered close contact. And so our response is going to be designed around putting a single individual into that risk circle and keeping others out unless they absolutely need to be there. Okay? And we'll talk about that response here in just a second. You got a question? Okay, go ahead.
Brett asked, what's the status of Spokane Fire Department's PPE supply?
That will come from our EOC, the Emergency Operations Center. We've done a inventory, and I think most everybody and most agencies have inventoried what they have. I think that question is better left for the EOC, and I'm going to direct those questions that are agency specific to them. The caveat to this that I think we need to be careful about, and we'll get into this, is high-risk procedures that are likely to generate more aerosols. So things like bag valve mask, things like intubation, things like CPAP, things like nasal cannula greater than 6 liters per minute, suctioning, things in that category are going to warrant an enhancement of the face mask to an N95 respirator or greater. Okay? So if I have to intubate somebody, then that N95 mask is a minimum for what you need to have on your person for PPI. Okay? If it is an encounter of I'm febrile, I have a cough, I'm sick, this looks like a suspected COVID patient on your screen or as you were notified by dispatch, then your minimum is going to be a simple face mask with eye shield or greater goggles, isolation gown, gloves. If you recognize that this person needs to have some sort of aerosol generating procedure to keep them alive, then that needs to be upgraded to an N95 mask if you'd only had a face mask on. Am I clear on that? Make sure I'm clear on that. Okay, go ahead. Another question.
Michael asked, is there any system in place to leave a patient at home to minimize exposures if they have a minor symptom and are a low-risk patient?
Yes, and we will get to that. So the question, actually you heard the question because she's got a microphone. Thank you. Yeah, we'll get to that. Okay. Minimizing contact. So all patients, regardless, so low suspicion COVID, high suspicion COVID, all patients, regardless, need to be questioned. I don't care if you show up on scene and they have a broken arm and they say, I just fell off my bike and I broke my damn arm. Your first question by a single provider is, have you had a cough or fever in the last 3 days? Okay? If they say yes, they get a surgical face mask. And that is for the benefit of what we call source control. Okay? As this spreads in the community, and what we've seen in Seattle is that people rush in because there was no clear fever. They didn't call for fever. They called for belly pain. So they don't hit positive on a screen for respiratory illness because they didn't complain of a respiratory illness. They said, my belly hurts. And you show up on scene and say, yeah, my belly hurts. And, oh yeah, I also have a fever and a cough, but I called you because my belly hurts, right? That's not your communication specialist's fault. right? They asked the questions that they're supposed to ask, and the caller revealed the information they wanted to reveal, right? It's up to us at every encounter to screen and say, have you had a fever, cough, or respiratory symptoms in the last 3 days? If the answer is yes, they get a face mask for source control, okay? And the receiving facility needs to know that we have provided them with that face mask for respiratory precautions, okay? Then the inquiry needs to proceed by a single provider standing at a distance of at least 6 feet when possible, okay? So that is my initial assessment. That source control face mask can be placed over a nasal cannula. If somebody needs nasal cannula greater than 6 liters, it needs to be supplied by a mask, okay? And that mask is sufficient to provide source control. So that becomes your face mask. An oxygen reservoir or oxygen mask can act as a source control face mask. And I want to limit the number of providers involved with the patient care to only essential personnel. So if this is not a critical call and everything that needs to be done can be done by a single provider, then it's that lead provider who initiated contact, broke that 6-foot distance screen, had appropriate PPE, and everybody else stands back, okay? Again, there are things in place to encourage folks to stay in home who are minimally symptomatic. Folks that need to be transported, transition of care should happen with only essential personnel. So ideally, one provider of a first responding agency to a single provider of a transport agency, and only in the circumstances where additional support is needed for those that are critically ill would I want more than what's necessary in the back of a rig transporting. I'm going to be very clear, I'm not saying that fire agencies are not transporting suspected patients. That is not what I'm saying. What I'm saying is I want to limit the number of personnel that are involved and break this 6-foot circle and put themselves at risk to the minimum required, okay? That doesn't mean that we are not responding to these calls. These are public citizens utilizing the 911 system. It is our job and our responsibility and our duty to respond. We are going to respond in the safest, most appropriate way based on the threat. Based on the threat level that we know it, PPI is protective enough that we can safely engage when it's appropriate. When the PPI level is appropriate, we can safely engage and manage these people without compromising our own health excessively, okay? That's part of what we do. That is our duty. That is our responsibility. And that's how we're going to proceed, okay? Question?
Brett is asking, what's your opinion
God,
on
Brett, why so many questions? Jesus.
of using IGEL, IGEL, over intubation?
We're going to talk about that.
Okay. And then one more question. Nancy asks, haven't heard of how we dispose of our PPE after treating a possible COVID-19 person. Red bag.
We're going to get to that too. We'll talk about doffing. And a lot of the doffing procedure is going to be based on what your specific agency has in the supply chain. There's standard doffing. I'll go over the most kind of standard doffing of what I've described here in regard to face mask, protective eyewear, eye shield, gloves, and a gown. But again, a lot of this is going to be agency specific to what you can receive in the supply chain. And we're going to encourage that each agency provide some sort of instruction specific to what they have available. Okay? Not a question, I'm sure.
Daniel asked, with regards to limiting exposure, has there been any discussion on having patients meet us at the door or even outside?
There hasn't been any discussion, but I don't think that it's unreasonable to ask when you respond to ask people that are capable of it to meet you at the door. I don't think that is unreasonable at all. And so when that single provider makes contact and knocks on the door, and somebody answers, I don't think it's unreasonable to stand back 6 feet from the door after you knock on a door, whoever answers the door, to ask them, are you the patient? If they say no, say, can the patient make it to the doorway for an interview? I don't think that's unreasonable. But I think it is unreasonable to ask debilitated people who cannot safely make it to the door to come to the door when you have PPE that we know will protect you during a patient encounter. Okay?
Can I
Mike.
just do a follow-up to that, maybe a clarification to that? Facilities, like skilled nursing facilities, like assisted living facilities, even HOC and UGM, where you're going for a chest pain, cardiac-related chest pain patient, but because there's a perception that that particular facility has a higher prevalence maybe of the disease,
Right.
we shouldn't be asking people to walk out from those facilities simply because of that. Is that?
No, I think that's accurate. And I think if you wanted to have a realistic, I mean, if you were really going to be realistic and rational about that fear, then everybody would drop their patients off at the sidewalk of the ER and never make entrance into the ER, right? That's the level of caution that if that was really reasonable, that's what we'd be doing. That's not what we're doing. These healthcare facilities, like I said, just because the elderly are more symptomatic doesn't mean the elderly harbor this disease in a higher concentration than anywhere else. Just because the homeless congregate at the House of Charity does not mean that the homeless have a higher concentration of this disease than the general population. Right now, we can presume that everybody has equal risk of being exposed to this virus. Healthcare workers probably are at higher risk than anybody else in the community. So if that was the case, nobody would show up to work. Because statistically speaking, we are the highest risk population. Okay? So avoiding high risk populations really makes no sense. We are the high risk population. Okay? So I think let cooler heads prevail here. Understand that we are at risk when we make encounters or when we approach people. That's what this PPE is for. And that's why we're going to make it very clear what is required, what the expectations are, and a lot of personal responsibility on doing the steps that are necessary to minimizing transmission by taking these appropriate measures and recommendations. Okay? I know I'm looking at you like you asked the damn question. I'm not going to do it, but minimizing high-risk interventions. So these are the things that would require, at a minimum, in addition to face mask, gloves, gown, are going to require an N95 level or higher. Okay? Nebulizer treatments, non-invasive positive pressure ventilation like CPAP, high-flow oxygen, bag valve mask ventilation, oropharyngeal suction, endotracheal intubation. Okay? Those are all considered to be high-risk procedures. Not all high-risk interventions are going to be avoidable. Okay? Some are going to be required depending on the clinical scenario, and full PPE is going to be recommended for these. So again, I'll reiterate, full PPE is an N95 face mask or better, protective eyewear in the form of a shield or goggles that fully enclose the eyes, gloves, and a gown. Okay? To minimize, the things that we can minimize are we don't want to be doing small volume nebulizers. So that is the evidence is lacking that a small volume nebulizer of albuterol and Atrovent is any better than a metered dose inhaler. Okay? So just because I plug it in and I nebulize it over 5 minutes doesn't mean that that drug is more effective. There's no evidence. We deliver it that way because we have a tradition of delivering it that way, and we like to deliver it that way, and it's efficient to deliver it that way, and it's easier to carry around a single dose of nebulizable albuterol than a meter dose inhaler that has 90 puffs, and I use one, and they're like, well, I got to toss this thing, right? Right? Because I'm not going to dose somebody 90 times, so it's really not reasonable for me to buy a box of MDIs for one-time use only. That's why small volume nebulizers are so good in the emergency setting, because I'm going to give a dose or two, and then they're going to go somewhere else. Either you're going to take them to the ER, or I'm going to discharge them home, or I'm going to admit them to the hospital, right? Most people who have COPD and asthma have meter dose inhalers. It's best when it's given via a spacer, but now I would encourage, and the recommendations are, that if somebody needs a breathing treatment, if somebody needs albuterol atrovent, that we have them provide the albuterol atrovent inhaler that they have, meter dose inhaler, and they use that as an alternative to an SVN treatment in patients we suspect COVID-19. Okay? Make sense? We want to ensure that there's adequate ventilation. If we're going to do an intubation or an advanced airway procedure, we want to make sure that we have adequate ventilation. If you can do this outside of an enclosed space like the back of an ambulance, that's probably better, right? If I have to do it in the back of an ambulance or rig or confined space, I want to make sure that there is appropriate ventilation, so doors open, HVAC on. Okay? So we're going to minimize risk in those scenarios where we have to intervene. When it's available, and there are limitations in the supply chain that we are actively working on, we want to use inline filters for ventilator equipment and BVMs. Our Pulmodine O2 Max filter that we use for CPAP is 99.99999 effective against the coronavirus. But that being said, I just got done telling you we want to avoid non-invasive positive pressure ventilation. We'll talk about skipping that altogether here in just a moment. BVM, post-intubation, bag ventilation, if available, an inline filter is recommended. And again, where there are gaps in the supply chain, we are working to fill those gaps. I can tell you that filters are a universal gap, okay? And we're actively working with other healthcare providers in the region to see what we can garnish for that. But these are very low-frequency interventions. Okay? We're not going to be intubating a lot of these folks, at least early on when our supply chain is somewhat limited in this regard. I don't see this as a common threat. This will be a rare occurrence. And again, I will reiterate that full PPE is adequate when I'm managing these people's airways. Okay? Filters, opening the doorways, using HVAC, these are all additional precautions that we can layer on to ensure that we're doing things as safely as possible, okay? In regard to endotracheal intubation, I understand that there are agencies that have, particularly in Western Washington, who have said we are not going to perform endotracheal intubation. We're going to go directly to an iGel, right? That is a strategy that's been adopted by a lot of folks. That is not a universal recommendation. The rationale behind that, as I understand it, is that you can maintain distance from the patient of an arm's length when performing an advanced airway maneuver. The problem that I see with this is that most of these, if not all of these, intubations or scenarios that we require advanced airway management are not going to be unresponsive, obtunded patients without a gag reflex. They are going to be people who are electively intubated for impending respiratory failure. Okay? We cannot use an eye gel on people with a gag reflex. It induces vomiting, which then puts you at a significantly higher risk for contamination. I do not like the idea of an eye gel in somebody who has a gag reflex intact. My understanding as of today, and again, recommendations will change, and if they do, I'll try and have the why attached to it so that it's clear, is that when somebody has impending respiratory failure, non-invasive positive pressure ventilation, or CPAP, should be avoided, and we should proceed straight to closed circuit ventilation, which would be endotracheal intubation. An eye gel that is not seated appropriately is no safer than BVM or CPAP in regard to the generation of aerosols. Okay? The only true closed circuit ventilation we have is going to be via endotracheal intubation. Okay? Closed circuit ventilation, right? And by closed circuit, I mean no opportunity for leaks around the tube. What I'm getting from the respiratory pathway goes straight into the tube. I'm bypassing the oral pharynx and the nasal pharynx. I should be moderately, it is believed to be the safest strategy to minimize exposure at this point, okay? It should be performed by your most experienced provider, okay? The most experienced provider needs to be performing this procedure. Videolaryngoscopy is the recommendation because, like people have been using eye gels, because videolaryngoscopy allows for the provider to be at arm's length when placing an endotracheal tube. So it provides that protective distance that is the theoretical protection from an eye gel by accomplishing the task with videolaryngoscope. A true rapid sequence intubation technique should be utilized, meaning once I pre-oxygenate a patient, right, I don't bag them up. I pre-oxygenate them with a mask. I provide induction with whatever my sedative is, etomidate, ketamine, Versed, whatever your drug of choice is. And then I follow that with paralysis. I don't bag valve mask that patient following paralysis. I proceed directly to laryngoscopy and intubation. There's no BVM. That is true rapid sequence intubation. So induction, paralysis, intubation. Okay, well, let me rephrase that. Pre-oxygenation, induction, paralysis, intubation. Okay, and then BVM in place on the ET tube after confirmation, okay, or with confirmation. There are some recommendations about currently in our what we have termed optimal sequence intubation, which gives us an emphasis on pre-oxygenation techniques plus apneic oxygenation techniques. The concern is that the high-flow nasal cannula, or what we term high flow, which is not true high flow, but higher flow oxygen via nasal cannula at 15 liters per minute likely produces excessive aerosols or droplet aerosols. And so therefore we should maintain all nasal cannula at less than 6 liters. So you can still do apneic oxygenation in my opinion. I just want to see that level of flow down to what our recommended range of less than 6 liters per minute. Okay? I hope that makes sense. So I know there was a question about intubation versus eye gel. That's my understanding and my recommendation currently for proceeding with patients who need advanced airway management. That being said, most of our urban transports are not long. And I think we do a lot of stuff en route because we have the means to provide treatments en route, and so we just reflexively do them. I'll bet you most of this could be delayed to the receiving facility and probably should be delayed to the receiving facility if at all possible, okay? So if I can pick somebody up who's in respiratory distress and I can provide them with adequate oxygen saturation of 88 or higher, 90 or higher by supplemental oxygen, then I think I would prefer to see you guys transport these folks rapidly, giving us advance notification that this is somebody who is on the verge in terms of respiratory distress, that you are that you anticipate they're going to need some level of intervention on arrival. Okay, but if you can postpone that to a receiving facility, I think this is a time to forego. Hey, I need to get another tube before I recert this year, or I'm a first-year paramedic out and I need 12 tubes in this next 3-year cycle. This is not the time to try and pick up tubes. Okay, this is a time to be reasonable and practice restraint. Just because we can do things, it may not be the best thing to do, but if you do meet a scenario where you say this has to be done, I think it's best to go directly to the definitive airway management tool that we have, which is endotracheal intubation by the best provider in true rapid sequence fashion. Okay? Clear as mud? Okay. A note on doffing PPI. This is where most of people's contamination will occur. And you've all seen, I'm sure, or heard of the training where people are sprayed with some sort of dye or pigmented liquid and then doff their equipment, and you can see how poorly they doffed and how they contaminated themselves during the process, right? You've all been aware of that. So what we know that most disease transmission occurs at the doffing process. So best practices are incorporating an assistant to the doffer as well as a spotter. So someone who's watching the process from a distance who can say, you touched them in the wrong spot, that's a contaminated glove, change it. Okay? And I think when that's available to us, we ought to be using an assistant and a spotter during these processes. You have a question, I'm sure.
Dan asked if we need to pre-oxygenate via BVM because of inadequate spontaneous respirations. Do you recommend a 2-provider BVM with 1 provider doing a quality 2-handed mask seal?
So I suspect that anybody who's going to be ventilated, right, or anybody that's going to need intervention is going to require more than 1 provider, right? Remember, we talked about limiting the amount of providers that are involved, essential providers. I would suggest that anybody involved in endotracheal intubation is going to need somebody else in full PPE providing protective measures. So in that circumstance, if I have to have BVM, then I want whatever provides me with the best seal, which would be a 2-person technique. But again, if I can get somebody, if I'm going to electively intubate somebody, right, then I want appropriate pre-oxygenation, induction paralysis intubation without the use of a BVM. If I have to BVM, I think whatever provides me the best face seal is going to minimize the risk of aerosolized droplets. Okay? So, doffing. First step, inspect for gross contamination. This is a spot that an assistant and a spotter can also participate in. Inspect for gross contamination. If visible, it should be decontaminated using a wipe. If the gloves that are involved in that process should be doffed and don a clean pair of gloves to continue with that process. So just nomenclature, donning or vernacular, donning is putting on PPI, doffing is taking off PPI, right? So once you have done a gross visual inspection, or once you've done a visual inspection and you've cleaned any gross contamination that requires the use of a wipe, then you're going to remove the gown and by ideally pulling it into a forward position in front of the chest and pulling it away from the body, keeping the external or exposed surface of the gown, wrapping it towards itself so that it can be pulled together. Sleeves are going to be rolled off so that exposed surfaces touch exposed surfaces, and you're left with contaminated gloves. The gloves, if you double gloved, you can take off the external glove to your clean gloves. If you only have a single layer, then you can remove those gloves, wash your hands thoroughly with sanitizer, don a new pair of gloves, remove your mask or eyewear, and then remove your gloves. What needs to be disposed of in a biohazard bag are going to be any things that are not reused. And I'm going to be very general about this because a lot of things can be reused and may be required to be reused based on supply chain, okay, and what we currently carry. And I'll talk to that briefly. After everything has been removed, the disposable items need to be placed in a red biohazard bag. Items that need to be decontaminated further can be placed in another bag that can be taken back to a station, or if you have wipes available and you want to wipe down or use a solution to wipe those down, then that can be done on site if it's available. But this is going to be agency specific based on what agencies have for PPI. So I would defer details to the individual personnel in charge of this at your respective agencies. I would encourage everybody when you return to your stations to do an adequate repeat hand hygiene with soap and water. And then just constant vigilance throughout the day in terms of its use in an effort to kind of maintain a clean environment. Obviously, we want to practice donning and doffing so that it's a familiar process to us. It's encouraged, it's recommended, as long as there is consideration given to supplies of PPE and the supply chain. So I think it's probably a really bad idea to burn through all your PPE practicing how to doff and don PPE. It's not unreasonable to sacrifice a limited amount as long as it doesn't compromise our ability to perform the duty at hand for reuse as a training PPI set that can be reused over and over again. Okay? A note on reuse of face masks and N95 respirators. This is a topic that has come up and will continue to come up as supply chain becomes limited. Reuse of surgical face masks we'll talk about first. This is acceptable, and the mask can be stored on the provider between incidents. Gross contamination or damage to the mask warrants replacement. And I'll just give you an example of this. When I'm on shift in the ER, I wear a face mask. Okay? I have the same face mask my entire shift. It loops around my ears and sits on my chin. Sometimes I take it off and I put it in my pocket. I reuse that same face mask. That is not considered for low-risk encounters, like average encounters with low-risk people. That is adequate for reuse. I don't dispose of it between patients. That is a source control for me so that I don't infect other people. I don't infect my colleagues. I don't infect my patients if I become knowingly ill. And it adds another barrier or layer of protection between me and the patient. Okay? And so I do that continuously throughout a shift. The only time I replace it is if I tear it or if it becomes grossly contaminated, or if I feel like my involvement with a high-risk patient warrants the replacement of it. Okay? Does that make sense? I hope. The reuse of N95 and N100 respirators is acceptable without high-risk encounters likely to generate higher concentrations. So any time it was used, that does not involve a high-risk aerosolizing procedure that we mentioned previously, that can be reutilized. The recommendations from NIOSH and CDC are that that be stored in a ventilated container, which can be as little as a paper bag with holes punctured in it, or a plastic container that's perforated to allow for air circulation and doesn't significantly compromise the contours of the face mask. So crush it, essentially, right? And that can be reused. Recommendations currently are 5 reuses or no more than 8 hours of continuous or interrupted use, right? So I can't go 24 hours in one, although I will tell you that places where supply chain is limited, greater than 8 hours is better than no mask at all. And people are using their N95s for greater than 8 hours when they only have one for their entire shift. So I wouldn't throw it away when my next best option is no mask at all, right? We're not there right now, but we may get there. And I think being responsible and judicious and eliminating unnecessary paranoia that kind of surrounds this sort of event, I think encouragement and reassurance that this strategy is approved by the CDC and NIOSH, which is intended to protect patients and providers, okay? Any questions so far? Yes.
I was just asked if we are going to rely on the surgical masks, or are we going to get more of the full face coverings at all?
So again, this is that, I suspect that is an agency-specific question, right? So questions regarding supply chain and what is available and how we're going to reuse things, I think is better left to the EOCs or whoever is in charge at the individual agencies. I can tell you that if we don't have disposable face shields, we are going to use face shields that need to be decontaminated, much like an N100 respirator or higher is decontaminated with a wipe that may be a commercial wipe if available, or maybe a 10% bleach solution if that's what's available. Certain things will be reutilized and repeat use, and will provide instruction on appropriate disinfection or decontamination of those reusable devices, okay?
Joe asked, since this disease can be asymptomatic in young, healthy people, are the first responders going to be tested to ensure we are not carriers and spreading the disease to our high-risk patients?
No. Nope, we're not. And the reason is we're not testing asymptomatic people. So asymptomatic people will not be tested for this disease. What we have in place and what has been recommended for healthcare centers is appropriate screening. So what current recommendations are for healthcare providers is that when you show up on shift, that you have your temperature taken and you are screened for signs of illness. If you pop positive, then you do not work, okay? Because then you are a symptomatic individual. But we don't have tests available to test asymptomatic people. We would exhaust in a matter of hours our entire supply of tests on asymptomatic people. Part of what I had mentioned earlier, and the reason I choose to wear a mask throughout my shift when I care for patients, is partly that reason. I don't know who is an asymptomatic carrier, and I want to add a layer of protection with a face mask that I reuse throughout a shift. And what if I'm an asymptomatic carrier? I took care of several immunocompromised patients in the emergency department last night as part of my routine job and responsibility. I wear a surgical face mask for every encounter so that they are protected as I am protected. So that is a more reasonable strategy than exhausting a scarce resource of a COVID test on asymptomatic patients. So we will not be testing asymptomatic people, okay? Back to that screening, I think it's very reasonable and probably recommended that when you show up to work, your temperature is taken and you're screened for symptoms. If you're positive, you're removed from the workplace. If you're off duty and you become symptomatic, it is your responsibility through the appropriate chain of command to notify whoever is your person appointed in your agency that you are symptomatic, and you will then potentially become a person of interest, okay? Which does not guarantee that you will be tested. Let me make that very clear. Does not guarantee that you will be tested. Testing is going to be predicated on availability of tests, okay? Yeah.
Where do you recommend drawing the line if staying home versus transport? What if they want to be tested? What is the area's testing available?
Yeah, what's testing availability? I will get into testing availability and options here shortly in that regard. But we do need, this is part of what when I talked earlier about our responsibilities as healthcare providers in terms of being leaders in the community, our responsibilities extend beyond when we are on shift. Our responsibilities also include when we are off duty, that we're not compromising our own health and the health of the people that we are going to care for and work with when we are on duty. So we need to be vigilant for symptoms. We need to be participating in the recommended social distancing and avoiding areas where we might be potentially exposed. Okay? Exposure does not equate to illness. I want to be really clear. Appropriate PPE significantly reduces your risk of infection. That's why we've made a big effort to outline specifically what is required for each response at a minimum level. And we want to enforce that, and I think there's going to be a lot of ownership by the individual, and I think we need to hold each other accountable that your entire team is demonstrating or is practicing the recommended precautions. Quarantine of exposed but asymptomatic providers with appropriate PPE is not recommended or necessary. So if I've been exposed and I had the recommended PPE, I do not need to be quarantined. There are CDC guidelines recommending extended quarantine for moderate to high risk exposures, which are outlined in the CDC, and I'm not going to go into detail here, for healthcare providers before they return to work. Our recommendations on PPE, with the instruction that everybody screen every patient prior to the encounter. Spitting all over the place, sorry guys, there goes my droplet precautions. Fortunately, we're in a 6-foot barrier in an empty room here. I think we can mitigate a lot of these under PPI'd exposures that would necessitate quarantine from the workplace. Washington Department of Health, I'm going to tell you, has a modified return to work strategy that involves mandatory face masks for asymptomatic exposed providers at work due to the potential significant impact on available workforce to help manage cases of COVID in the community. So the CDC has imposed pretty strict guidelines on who can return to work and who can't, but they've also acknowledged that in communities that are heavily impacted by this disease, that essentially, for lack of a better term, crisis standards of care will apply. Washington State has met that criteria And we may move into a pattern that is not consistent with the CDC recommendations, but is approved for or approved by the Department of Health. But if we do that, you can expect that there will be a requirement that while you are on duty, that you wear a surgical face mask. Much like I just told you I wear when I'm at work, I wear a surgical face mask the whole time. We may employ that at some point in the future. You may see that come down the pipe where you are exposed, but you're going to work. You're going to wear a face mask while you're at work, and we're going to continue to do rigorous screening for fever and symptom reporting. These recommendations are going to be agency specific, and they are going to require coordination from medical and operations branches in those respective agencies, because a lot of it is contingent on what our workforce availability is and what the demands of our responsibility to the community is. And it's a fine balance between providing the care that that is our duty, but also protecting us as best as we can while we do that. So I know a face mask at work all shift seems like a miserable thing, but people are doing it, and we may be doing it in the future also. So if you see that, don't be alarmed. It's not us cutting costs. It's not us trying to salvage the bottom line. This is something that has been scrutinized and is approved by the Department of Health, and part of their job is to make sure that we protect our community and protect ourselves, and this seems like a reasonable balance and a reasonable ask. So you may see this in the future. I think there's a question.
Yeah, Tom asked, when a firefighter is screened at work, what is the temperature cutoff point?
Greater than 100 is the recommendation from the CDC. I am not going to make recommendations for each individual agency. I know the audience here encompasses more than just the agencies I am involved with. So I have to be very, and if you haven't noticed, I've been very reluctant to make agency-specific or broad recommendations. But I will note that the recommendations from the CDC are greater than 100. What individual agencies choose that's a better question directed toward whoever the appointed person is in that agency to field those questions. But CDC guideline is greater than 100. COVID testing, a note on that because this is going to be a question and will continue to be a question. When we had a low community prevalence in the region, we were testing according to CDC recommendations. Clearly this was a strategy that was clinical rather than epidemiological in emphasis. And we'll talk about that in just a second. So we have not tested a lot of people. So I can tell you that the number of confirmed cases is probably in excess, or the number of cases is probably in excess of what our confirmed cases are, okay? And that is because we have not had a panacea of testing facilities or equipment where everybody is tested. So I'm sure that our numbers underestimate what is here in the community, okay? And that's because we had relatively rigorous criteria for testing, and we had limited access to testing, and so those tests were reserved for our highest risk population. The usual turnaround is 3 to 4 days. Most persons under investigation are discharged back to their homes after they've been tested on self-isolation or quarantine with a callback of test results. In University of Washington, where they've lightened up some of those restrictions, my understanding and what's been retorted to me through unofficial, some official, some unofficial reports, is that there's about a 5 to 10% positive test when they started to expand their testing numbers. So people who present with a COVID-like illness, 5 to 10% of them were testing positive. I heard upwards of 15% in other areas in Western Washington also. That being said, the difficulty with testing is we don't have a gold standard test, right? So we don't have a great comparison test. This is a new test. The sensitivity and specificity of these tests are not entirely known. When you start testing asymptomatic people and you have a low pretest probability, you are likely to encounter false positives. So you inflate the number of positives when you test everybody, particularly those with a low pretest probability of disease. And so you have to kind of apply a strategy of who am I going to test? Let's try and restrict our testing to people who are most likely to have the disease. So the dilemma is, do I test everyone and I inflate the results with positives, with false positives, or do I test very few, only my highest risk people, and underestimate the community prevalence of the disease? In early emergence of these diseases, we tend to test fewer people. What we're seeing is that as tests become more available, as the prevalence in the community increases, there is a push to identify more folks out of concerns for public health. Now, what we need to be sure of is that we're not wasting tests on people who are not symptomatic, because that is a very low pretest probability group of patients, and we're not testing people that probably wouldn't benefit from the knowledge of a positive test. And it may be that we are going to tell people you have a COVID-like illness, and so we're going to presume you're positive. You don't need a test because my recommendations are going to be the same. Self-isolate, don't go around people, 14 days without close exposure to individuals, remove yourself from public, don't go to work, stay away from people, don't go next to your wife, sleep in the other bedroom, couch, whatever. You need social distancing and employ the typical recommendations we're going to make for people regardless at some point whether or not your test is positive or not. And it may be that we just end up telling people due to lack of tests that you have a COVID-like illness, we're going to presume it's COVID positive, go home. And most people, 80% of people, manage this at home. Okay? Question? No question. Okay, good. Let's move on. What to expect? We don't know exactly how long or what the community impact is going to be, but experts expect that this is going to last into the summer months. And if we do the appropriate recommendations for mitigation of transmission, we'll be able to reduce the burden on the healthcare system, but that will draw out the number of days on that curve. So instead of getting hit all at once, it will be hopefully a slower trickle of new cases that we can handle, but that's going to draw this out. But I think from a public health perspective, that is the best strategy. Many of us and in the community are going to contract COVID-19 symptoms and probably the disease, and will only experience typical cold and flu symptoms. We are going to have a heavy emphasis on the use of standard PPE for respiratory illness and upgraded PPE for patients with known positive exposure to COVID-19, which puts you at a great risk. And I suspect that this is going to be broadened to anybody with fever and respiratory symptoms in the near future. So if you see that change happen, don't be surprised. Expect delays in dispatch for appropriate screening to take place while we're still using a 36-card pandemic tool, and enhanced precautions at facilities where you are responding. Don't be alarmed and don't be irritated if you get to the front desk of a nursing home and they ask to take your temperature or ask you to participate in some pre-decontamination procedure before you enter the building. That is for a preponderance of concern for their residents, and we will oblige with those concerns. Expect scarce resources to continue and to potentially increase. We need to conserve N95 masks for when they're required or recommended. I would encourage appropriate reuse of those. These shortages are nationwide, and many suppliers are on back order. This is not a Spokane or agency-specific problem. This is a universal problem, and part of the reason that we've seen the initiation of emergency-level responses from governing bodies in Idaho and Washington recently is so that we can access potential national stockpiles of these supplies, okay? So there's politics and policy that's behind that. Our current status in Spokane County, as of what I knew 2 hours ago, is that we had 3 cases here in Spokane that have been confirmed, many persons under investigation that are still pending. It is here. It probably has been here. We know that our confirmed cases underestimate the true number, and usually there is a delay, partially and due to the turnaround time of testing. I would expect that this number, now that testing restrictions have been loosened, and I want to be very cautious about saying that because it does not mean that it is readily available to everybody, but we are seeing some increased testing based on requests by the Spokane Regional Health District. I suspect that with more testing, we'll see more positives, so I expect that this number will climb here shortly. Don't be surprised by that. That's probably more a reflection of the availability of tests rather than the prevalence in the community. There are discussions and planning in place for off-site screening centers and telemedicine strategies that are being discussed to minimize unnecessary emergency department and urgent care utilization. What we do not want is to overwhelm the emergency departments and places where our most critically ill patients are elderly, are folks with comorbid conditions, our folks with immunocompromised immune systems come and congregate for care. We don't want to bring a bunch of symptomatic people just because they want to know if they have it or not. So the strategy is to find off-site testing or off-site screening centers. That does not mean that everybody that shows up there is going to get tested. It becomes an off-site screening center to help answer the question of who may be carrying this disease and who may not be. I can tell you that we are advocating in EMS that our folks that are in the field and providing care are prioritized, and we have been reassured that all healthcare providers, EMS included, are part of a priority group or cohort that will be have better access to the potential for testing than the general public. And I'm going to leave that at that. Again, screening does not guarantee testing. Much of our testing is going to be predicated on our supply of tests. Question?
Yes. Ed asked, once you get the virus and wait the designated time, what is the chance for reoccurrence?
So reinfection rates are going to be low because of the fact that, again, like our fire analogy, if I've had it recently, I've had an immune response, I've beat it, I'm ready for it to come around the corner again. When it shows up again, I'm going to fight it effectively, and reinfection is not a concern. So after the appropriate strategies for managing people who are ill with COVID-like illness or COVID concern or COVID positive illness, your reentry into society is should be unrestricted. But I would ask that if you have had it or you do get it and you do the necessary quarantine and recover, when you come back to work, that you are not cavalier in how you utilize PPE and participate or comply, I should say rather, to the recommendations for what we are requiring of folks during each encounter. That includes our approach, our questioning, our social distancing requirements, etc. Hope that answers the question.
Next question from Brett. Is there going to be a change in response priorities for FD resources to urgent care facilities, doctors' offices, etc., for calls from AMR for transport only patients and other non-critical patients?
That is a really good question. I don't have an answer to that. I suspect that if it is going from a medical office and with instructions to move to a higher level of care, and they're not a critically ill patient, that we could definitely look into ways to minimize unnecessary encounters. I don't know of anything, and I don't have anything in place right now to address that specifically, but that is a really good question, and I'll try to get an answer back to that. ESO, for those that have ESO, has a tracking tool for COVID-like illness and PPE documentation. One of the things that's going to come up is positive COVID cases in the community, and we want to be able to backtrack and see and confirm what level of PPE was utilized for that encounter as a way to better track its effect on our members. So I'm going to ask that anybody who you have suspicion for a COVID-like illness, that you use the COVID-like illness screening tool and document your level of PPE on each of your records in ESO so that we have ready and quick access to it. I would make that, those of you that don't have ESO, I would make that part of your documentation with each of these cases, because as we backtrack to find out who the crews were, what the clinical scenario was, I want to be able to see that, yes, appropriate PPE was in place and documented, so our response to that potential exposure can be appropriate. So my ask is that, and I know this drives you guys crazy, and I know that I hammer on this all the time, but here's another example where I'm going to ask you to document more rather than document less, because we need to protect you, and this is the most efficient way that I can guarantee that people were appropriately protected for the encounters that they had. And it may be that you had an encounter that you were unbeknownst to you or you were exposed, and I want to be able to go back in and say that, yep, even though we had minimal suspicion, we used the minimum level of PPE, and we are protected based on that encounter, okay? There is a pandemic triage tool that is approved by the Spokane County MPD, Dr. Nania, as well as the Spokane Regional Health District, Dr. Lutz, that will be introduced in the near future. Dr. Nania asked me to discuss it today. This will be a Spokane County-wide recommendation, not agency-specific, and not coming from any particular EOC. I was asked to relay this message by Spokane Regional Health District and Spokane County MPD office. So the pandemic triage tool, this is how it will read. In most young, healthy patients with a COVID-19 will present as a flu. We know the course, although uncomfortable, will be benign and therefore not require EMS transport and hospitalization. Patients with mild symptoms may be treated at home with hydration, antipyretics, so Tylenol and ibuprofen, and rest, and only be transported to the hospital should their symptoms worsen. The patients at greatest risk are older and those with comorbid conditions. This is not new. You all know that. During the pandemic period, patients with fever, cough, shortness of breath should be assessed according to two variables. So this is all patients, and remember, our initial response, anybody with fever, cough, shortness of breath needs to have a face mask placed on them for source control, and the initial interview to be completed at 6 feet until appropriate PPE can be donned. Part of that initial interview will be a vital sign profile. So we have two profiles here. One is a vital sign profile. So regardless of age, any patient, your otherwise healthy 21-year-old guy who's completely unaffected by any community illness and still runs 15 miles a day, whatever. I don't care how healthy they are, regardless of age or comorbid conditions, respirations greater than 30 per minute warrant an encouragement for evaluation. A pulse ox less than 90 warrants encouragement for transportation. A systolic blood pressure less than 90, a pulse greater than 125, or an appropriate age adjustment or altered mental status, all should be considered higher risk, and we should encourage transport. Less than that, we should encourage people to remain in their homes. That just because they come to the hospital does not warrant testing. That is not the appropriate testing center. We want to make sure that they are contacting their primary care providers or utilizing resources that do not congregate the most critically ill in our community in one location, which tends to be our emergency departments, okay?
Along that line, both hospital systems, Kaiser, Chaz, all have virtual visits, and they're ramping those up to be 24 hours a day. So that's another piece that we need to, and that just came about in the last 48 hours, and they're really pushing that.
So part of this is going to be, we can't just go up and say, well, you don't meet criteria, we're not going to transport you. This conversation needs to be, I understand that you are sick, I understand that you are concerned, I understand that there is a fear of COVID in our community. Most people are going to recover from this who are otherwise healthy as if it were the standard flu-like illness and do not require hospitalization or testing. You do not meet our immediate criteria for recommendation for transportation to an emergency department, but here are some other options that are available to you to help alleviate your concerns and help you manage this disease, right? That's how this conversation needs to take place. The other group or cohort is our high-risk profile. These are our high-risk patient, greater than 60 years old with flu and respiratory symptoms, or people with comorbid conditions. They should be evaluated. If they call 911, they have comorbid conditions, they're greater than 60 years old, they have a fever and flu-like symptoms, those people we should recommend transport. If they choose to remain in their homes, we still give them the same information that's available in the community. We should get a refusal of care from them or a refusal of transport based on our recommendations, and I would document clearly we recommended transport based on our transport criteria for COVID. And specifically, you could cite age, comorbid conditions, or the vital sign abnormality. Patient refused, have them sign, still provide them with the material that's available to them. And make sure that they are provided with the appropriate information or instructions to ensure that they have contact with a healthcare provider or healthcare system, okay? So that is what this pandemic triage tool to minimize unnecessary transports will look like in the community as it's rolled out. Here is one of the brochures that's been recommended. This is a CDC brochure. If you have possible or concerned COVID, stay at home, monitor your symptoms, get rest and stay hydrated. If you have a medical appointment, call your provider ahead of time and let them know that you may have symptoms. They may cancel that appointment because most people do not require treatment for this. And that puts you in a proximity to people who are potentially compromised or at high risk. For emergencies, dispatch, call 911. But again, part of your instruction to these people are appropriate indications for calling 911, appropriate high cough and sneeze and hand hygiene and stay away from people and don't share personal items, blah, blah, blah. You know all the appropriate things. So, once again, I went over time by 20 minutes. I apologize. I want to open this time up to questions. I'm sure there are a number of unanswered questions. I will be available for questions for folks, but I would ask that you also, due to the fact that I can't field all of these questions, I would ask that questions regarding potential contamination or potential exposure, questions regarding supply of PPE be directed to your agency-specific contact person or EOC, and I will work with those people in the capacity that I have to ensure that everybody's concerns are addressed. Again, I'm going to reiterate that unique situations demand unique responses. This is a healthcare crisis and will continue to be a healthcare crisis. We are going to be asked to operate under conditions that put us at higher risk than the general community. Just the fact alone that we show up to work and we agree to take care of sick people, we have put ourselves in this position. I would ask that you do it proudly, do it responsibly, be diligent, be focused, be professional. I think that we have a very unique opportunity to be a critical element of folks that are making a significant positive impact on our community and in a situation that probably many have never experienced or seen before. I kind of have this bizarre thing that I hope bad things don't happen to people, but if they do, I hope it happens to them when I'm on shift, because I want to be a part of something big, right? That's why we do emergency care. We want to be part of something big. I don't know if it's because we're selfish. I don't know if it's because we like action or we're adrenaline junkies, but some reason we found ourselves in a circumstance of being the safety net for a community in need. Again, I would say be proud of that, and let's do our jobs well with our chin held high, understanding that we're going to have to be careful, but that I think that we are capable, very capable, of doing this the right way and emerging from this on the back end, able to have some lessons learned and a profound, probably agency-changing, life-changing experience here. So I'm glad to be a participant in it with you all. And I think I'll just field questions at this point.
From Kate, is there a recommended hospital these patients that meet transport criteria should be transported to?
Any hospital is capable of taking care of these patients. Initially, we had a special pathogens unit at Sacred Heart where patients were being preferentially transported to from outlying facilities because of where we were at in a containment model in trying to quarantine and contain the disease. We are well beyond that. I can tell you that persons under suspicion are throughout the hospitals and every hospital and in the ERs. And if you look to Seattle, entire ICU wings have been converted to COVID center or COVID-focused cohorts to try and contain it within the hospital. But every hospital is going to share the burden of this disease right now. So they can go anywhere, and anybody should be able to manage them. You may be taking critically ill patients. Those of you that are involved in critical care transport may find yourself transporting some of these folks from one level of care to a higher level of care based on capabilities that might be available, like ECMO. But we're not there yet. Wouldn't surprise me in the future if we go in that direction. So there's maybe some circumstances where there's hospital-to-hospital transfers, but in general, there is no preferred hospital for these patients to go to. The major medical centers in our community should all be able to and willing to receive these folks. Any more questions? We are, okay. Well, there's a little bit of a delay in the feed here, so we'll just kind of wait a little bit with an awkward silence until something else shows up. Again, oh, in terms of negative pressure rooms and being able to ventilate, yeah, they've had to change HVA systems to try and create, instead of a negative pressure room, create a negative pressure wing, which has been real difficult in terms of trying. And the truth of the matter is, we're doing our best to reduce transmission, but like most people have heard, and like our analogy with a fire, a wildfire, is that really sometimes the only thing that slows this down is that enough people got infected by it and survived that there's just no more fuel. And I suspect that will probably be our greatest variable in terms of seeing a decline and surge in this disease. So, all right, and no more questions. We'll conclude. Thanks for your time. Appreciate it.